Okay, let's unpack this. Imagine a field of medicine that isn't just about healing the sick,
Hmm.
but about fundamentally sculpting the very future of a nation.
Right.
It's about ensuring every young life doesn't just survive, but truly thrives and reaches its absolute highest potential, physically, cognitively, emotionally.
Mhm.
Today, we're taking a profound deep dive into the fascinating world of pediatrics, specifically through the unique and challenging lens of India, a nation facing immense, really scaled up health challenges, while at the same time making remarkable, even pioneering strides in this vital area.
Indeed. What's particularly striking here, I think, is how this isn't merely a branch of individual health.
Yeah.
It's a profound public health discipline,
Right.
deeply intertwined with a nation's destiny and its long-term societal well-being. Throughout this deep dive, we'll uncover why a child is fundamentally not a miniature adult and what that unique biology means for their specialized care.
That's such a key point.
It is. And this exploration naturally raises an important question. How does a country as vast and diverse as India tackle the immense complexities of child health? From the most rural villages to its bustling urban centers, and maybe even how it can lead the way for other developing nations.
Exactly. Our mission for this deep dive is to go beyond the surface. We're going to extract the core professional level insights from a comprehensive medical text, our source material today, to help you understand the foundational principles of pediatrics.
Right.
We'll trace its fascinating historical journey within India, confront the stark realities of child mortality that have long challenged the country, and finally explore the incredible, multi-layered, and often ingenious strategies India has put in place to address these very challenges. By the end, you'll not only possess a comprehensive understanding, but you'll truly grasp the intricate dynamics of this field, much like the elite professionals operating within it. So when most of us hear the word pediatrics, our minds often jump to, well, routine vaccinations, maybe a quick checkup, or just a visit to the kid doctor.
Sure, the common perception.
But the true scope of this discipline, as laid out in our source, goes so much deeper than that, doesn't it? Our comprehensive medical text defines pediatrics as the branch of medicine specifically dedicated to the care of children and adolescents, encompassing everyone from birth right up to 18 years of age.
There's a huge range.
It is. The term itself is rooted in fascinating history, derived from the Greek words paedopaes, meaning a child, and iatros, which translates to healer.
Child healer. Makes sense.
What I find incredibly profound is its overarching goal: to enable a child not just to survive illness, but to remain healthy and, most critically, to attain their highest possible potential of growth, development, and intellectual achievement.
That phrase, highest possible potential, is so powerful.
Isn't it? It's a field literally about fostering human potential from the very beginning, laying the indispensable groundwork for a healthy, productive future generation.
That's a crucial point. If we connect this to the bigger picture, it really underscores that pediatrics is fundamentally about prevention and long-term societal well-being. It reaches far beyond merely treating immediate illnesses.
Right.
When we talk about child health, it's not a narrow clinical focus. It encompasses a broad spectrum of integrated approaches, strategic interventions, and proactive measures designed to preserve, protect, promote, and restore health.
At both individual and population levels.
Exactly, at both the individual level and across entire populations.
Right.
This means a pediatrician isn't just a physician specializing in individual healthcare for children. They are inherently contributing to the public health and future prosperity of an entire nation.
It's a massive responsibility.
It is. Consider the profound implications of consistently ensuring every child reaches their highest possible potential. What kind of society does that create? Imagine a future workforce less burdened by preventable chronic diseases, more innovative, truly benefiting from that cognitive leap enabled by early childhood nutrition and stimulation.
That's the real dividend, isn't it?
That's the real dividend of pediatric investment. It transforms individual well-being into a collective strength that drives national development.
But here's the concept that truly reshaped pediatric medicine, one that might even surprise you, and it's probably the single most important takeaway for anyone trying to understand this field: the fundamental principle that children are not miniature adults.
Absolutely central.
This concept completely flips our intuitive understanding of health on its head, because you simply cannot take adult medicine principles and merely scale them down for a child. Our source explicitly details this, emphasizing that pediatric biology is unique. Children have distinct risk factors for disease compared to adults. What's more, the clinical manifestations of childhood diseases can differ significantly from how those same diseases might present in an adult.
Yeah, fever means something very different in an infant versus an adult.
Exactly. For instance, a common fever in an infant might signal something far more serious. And fascinatingly, many disorders are entirely unique to children. They simply don't occur in adults at all. This unique biology also means that drug dosages for children are highly specific and carefully calibrated. They're never just simple mathematical derivations of adult dosages.
A critical safety point.
Absolutely. And the importance of wholesome nutrition for children is even more critical. It's not just for basic survival, but for ensuring their proper, rapid growth and neurological development, which is a continuous and incredibly dynamic process throughout their early years.
That's absolutely vital to grasp. This raises an important question. If we failed to truly understand and embody this fundamental principle, that a child is not a miniature adult, what are the potential and often devastating consequences?
You can imagine.
We could see misdiagnosis, incorrect or even toxic dosing, and delayed or entirely inappropriate interventions. It necessitates a completely different mindset for diagnosis, for treatment protocols, and even for preventive care strategies.
A whole different approach.
Completely. Think about the incredible rate at which a child's body changes compared to an adult's. Their organs are still developing, their immune system is maturing, their metabolic rates are vastly different.
Yeah.
Their responses to medication can be profoundly distinct, and a dosage that's safe for an adult could be catastrophic for a child. Similarly, their nutritional needs are dynamic and incredibly specific, crucial for rapid brain development, bone growth, and organ maturation.
And failing to meet those needs.
Failing to provide wholesome, tailored nutrition doesn't just impact immediate health. It can have irreversible long-term effects on cognitive function, physical stature, and predispose them to a cascade of other health issues, including chronic adult diseases later in life.
Wow.
This profound difference underscores precisely why pediatricians require such specialized, dedicated training and why the field itself is so distinct, requiring a unique body of knowledge and clinical approach.
So, what does this all mean for the discipline itself? It means pediatrics isn't just a broad field, it's a truly intricate mosaic of highly specialized areas, constantly pushing the boundaries of medical technology while simultaneously emphasizing accessible community and home-based care.
That dual focus is key.
Right. Our source describes it as a fascinating specialty, encompassing care all the way from the tiniest, most vulnerable premature neonates right up to complex adolescents transitioning into adulthood. The discipline has impressively branched into numerous well-developed super specialities, each focusing on a specific complex area of child health. We're talking about neonatology, which handles newborns.
Critical care for the tiniest ones.
Exactly. Then nephrology for kidney conditions, pulmonology for respiratory issues, infectious disease, critical care, neurology, hemato-oncology for blood cancers, endocrinology for hormonal disorders, and cardiology for heart conditions.
It really shows the depth.
It does. This showcases the incredible depth and complexity required. It's a field that seamlessly integrates intensive care, utilizing the most sophisticated technology for critically ill children, with providing essential, foundational home care to newborns and children in their own environments.
High tech and high touch, essentially.
Perfectly put. This demonstrates its dual nature as both a state-of-the-art clinical science and a rich public health discipline. This dual role demands that medical students possess competencies for the comprehensive care of both healthy children, focusing on growth and development, and sick children managing acute and chronic illnesses.
That dual nature is indeed what's so fascinating here. Cutting-edge clinical science meeting robust public health. While pediatrics embraces sophisticated technology for intensive care, it simultaneously recognizes the foundational importance of accessible community-level care, especially in a country like India.
Right, the context matters.
Absolutely. But even with all these advancements, the field still contends with an unfinished agenda, specifically the persistent and heartbreaking challenge of high child mortality due to common yet often preventable causes.
Things like pneumonia, infections.
Exactly. Pneumonia, severe neonatal infections, complications from preterm birth, diarrheal diseases, birth asphyxia, and vaccine-preventable illnesses. This highlights that despite the advancements and the growth of superspecialties, fundamental public health challenges remain.
And the benefits need to reach everyone.
Precisely. The benefits of advancing pediatric specialty care must reach all children, regardless of their socioeconomic status or geographical location.
Mm.
And beyond this immediate survival agenda, there's a significant new paradigm emerging.
Okay.
An increasing body of knowledge on the pediatric origins of non-communicable diseases of the adult.
Linking childhood health to adult chronic illness.
Exactly. This is a profound shift in thinking. It connects the dots between early life experiences and long-term adult health, emphasizing that primary prevention and early detection of adult disorders is becoming an increasingly important goal of pediatrics.
So investing in kids is investing in future adult health.
It means investing in child health is not just about the child. It's a direct investment in adult health, in an innovative workforce, and in the overall societal well-being for generations to come, a truly intergenerational impact.
That's huge.
And furthermore, our source reminds us that adolescence offers a crucial second chance in life to shape good lifestyles, instill healthy habits, and prepare young people for a healthy, productive adulthood, emphasizing the long-term, holistic scope of the field. #2, a historical lens on child healthcare in India.
So, having explored the foundational science that defines pediatric care and its evolving scope, let's now anchor this understanding in time. It's fascinating to consider how this sophisticated discipline we've just described actually took shape over centuries.
History gives perspective.
It does.
Yeah.
While medical care for children has deep ancient roots found in the venerable Indian, Greek, and Chinese health systems, pediatrics as a formal specialized medical discipline is relatively modern.
Relatively speaking, yes.
It truly began to take definitive root in Europe and the U.S. in the 19th century with the establishment of some of the world's first famous children's hospitals.
A turning point.
This marked a pivotal moment, signaling a fundamental shift in how childhood illnesses were perceived, valued, and critically treated.
That historical perspective is crucial. If we connect this to the bigger picture, the establishment of dedicated children's hospitals signals a profound societal evolution. It moved beyond simply treating children as small adults
Right, that key distinction again.
to recognizing their unique physiological, psychological, and developmental needs and vulnerabilities. This led directly to the creation of specialized care environments and distinct medical practices dedicated solely to them.
So it wasn't just science, but also value.
Exactly. It's a reflection not just of increasing scientific understanding, but also of a burgeoning societal empathy and commitment to the welfare of its youngest members. This shift laid the intellectual and infrastructural groundwork for the formalization of pediatrics worldwide.
And India, true to its independent spirit, systematically built its own pediatric infrastructure. These states tell a remarkable story of deliberate, progressive development.
Let's hear them.
The first child hospital in India, the BJ Hospital for Children in Mumbai, was established in 1928. Quite early,
By
actually.
1928, okay, a pioneering step.
Then formal education followed rapidly. A postgraduate diploma in pediatrics was started at the same hospital in 1944.
Building the expertise.
Exactly. And full-fledged postgraduate degree programs began in the 1950s. This shows a clear intent to professionalize the field. Fast forward to the mid-1990s, and pediatrics achieved a major milestone.
Becoming independent in MBBS.
Yes, becoming an independent subject in the MBBS course, integrating specialized child health training into the very foundation of all medical education.
That's a big deal for scaling up knowledge.
Huge. Following this, the first Doctor of Medicine, or DM, programs in pediatric super specialities began to emerge, reflecting the field's growing complexity. Neonatology saw its first DM program in 1989 at PGIMER, Chandigarh,
Right.
followed by pediatric neurology at AMS in 2004.
So specialization deepening over time.
Definitely. Today, our source tells us that half a dozen institutions across the country now run DM programs in various pediatric specialties: nephrology, pulmonology, critical care, hematology, oncology, cardiology, endocrinology. The list goes on.
A whole ecosystem.
It isn't just growth. It's a strategic phased development of a world-class pediatric ecosystem.
What's particularly fascinating here, I think, is the relatively recent emergence of pediatrics as a distinct and independent subject at the MBBS level in India, only happening in the mid-90s.
Seems late, almost.
It does. But it points to a conscious and critical effort to integrate specialized child health training into the very foundation of medical education. That's indispensable for improving child health care at scale across such a vast and populous nation.
Makes sense.
The growth from a single pioneering hospital to multiple institutions now offering advanced DM programs in a diverse range of subspecialties demonstrates a significant and sustained commitment to developing world-class pediatric expertise within the country.
It's that systematic building you mentioned.
Exactly. This systematic building of infrastructure, from foundational training to highly specialized tertiary care, is absolutely essential for effectively addressing the multifaceted and complex health needs of children across India.
Transitioning from these advancements to the stark and often heartbreaking realities, well, these numbers are truly sobering.
They are.
India, astonishingly, has the highest number of childbirths and child deaths for any single nation globally.
That's a staggering statistic.
It is. Our source reveals that each year, a staggering 26 million babies are born in India, which accounts for a full 18% of the entire global birth cohort.
18%?
And in 2015, out of the 5.95 million under 5 child deaths worldwide, an astonishing 1.2 million, a full 20%, occurred right there in India.
1/5 of all global child deaths.
Yes. The under 5 mortality rate, or U5MR, in 2016 stood at 39 per 1,000 live births. The text describes this as unacceptably high, especially given India's growing stature as an economic, scientific, and strategic global power.
Unacceptably high. That phrasing is stark.
It is. To truly grasp the scale, consider these comparative U5MRs from 2016. Japan at a remarkable 3, the UK at 4, the USA at 7, Sri Lanka at 10, China at 11, and Brazil at 16.
That comparison really puts 39 into perspective.
It really drives home the immense scale of the public health crisis India has been grappling with. Our source poignantly states that great nations not only have negligible child mortality, but also ensure good health, nutrition, education, and opportunities to their children.
A powerful statement about national priorities.
And here's a critical, often overlooked point to highlight. Female children in India historically face gender bias in access to healthcare and nutrition.
The gender dimension. Crucial.
Which prompts the powerful and deeply ethical statement that a civilized society nurtures all its children, girls and boys alike, with love, generosity, and benevolence.
This immediately raises a crucial question. What does it truly mean for a nation's long-term future when a significant portion of its youngest, most vulnerable population is lost before their 5th birthday?
The potential lost.
The economic, social, and human implications are absolutely immense, representing a profound loss of human potential. Beyond the sheer statistics, the explicit mention of gender bias is critical. It underscores that health outcomes are never purely medical. They are deeply rooted in sociocultural determinants and systemic inequalities.
It's not just about medicine, then.
Not at all. The fact that girls might face unequal access to healthcare and nutrition means that effectively addressing child mortality in India requires not just advanced medical interventions, but also profound, sustained societal changes to challenge deeply ingrained biases.
A much bigger challenge.
Absolutely. If we connect this to the bigger picture, achieving equitable health outcomes for all children, regardless of gender, caste, or socioeconomic background, is not just a moral imperative, but a fundamental marker of true societal progress and a nation's commitment to its own future strength and prosperity.
Let's unpack these mortality rates even further, because these aren't just dry acronyms. They represent critical, vulnerable windows in a child's life, showing us exactly where to focus interventions.
The different timeframes, yes.
The under 5 mortality rate, U5MR, as we just discussed, is deaths under age 5 per 1,000 live births, 39 in 2016.
Okay.
Then we narrow the focus. The infant mortality rate, IMR, looks at deaths under age 1 that was 34 per 1,000 live births.
Still high.
And zooming in even closer, the neonatal mortality rate, NMR, covers deaths under 28 days of age recorded at 24 per 1,000 live births.
The first month is clearly critical.
Critically important. To break that down with even more precision, the early neonatal mortality rate, ENMR, covers deaths under just 7 days of age. That was 18 per 1,000 live births.
The first week? Wow.
And the late neonatal mortality rate, LNMR, covers deaths after 7 days but before 28 days at 6 per 1,000 live births.
So the bulk is in that very first week.
That's the stark reality. The neonatal period, those first 28 days, accounts for almost 60% of all under 5 deaths. Even more acutely, the NMR alone accounts for 70% of all infant deaths.
70% of infant deaths in the first month.
This granular data tells us with powerful clarity exactly where the most immediate, critical, and vulnerable challenges lie in those very first weeks of child's life.
What's particularly striking here is how this detailed data precisely pinpoints the most fragile and high-risk period, the initial 28 days, and especially that crucial first week.
Undeniable.
This unequivocally suggests that interventions in immediate postnatal and rigorous neonatal care are paramount for significantly impacting overall child mortality.
Yeah.
If a nation can effectively improve survival rates during those initial, highly vulnerable days, it will undoubtedly have a profound and cascading effect on reducing both infant and under 5 mortality rates.
It's where you get the biggest bang for your buck, intervention-wise.
In many ways, yes. This granular understanding of mortality rates isn't just academic. It's absolutely essential for designing highly targeted, maximally effective, and resource-efficient public health strategies that can yield the greatest impact on child survival.
Despite these previously grim statistics, there has been significant and encouraging progress in India, but it also clearly highlights where the stubborn challenges still remain.
Progress is important to acknowledge.
Definitely. Our source shows a steady and commendable decline in child deaths. The U5MR declined by almost two-thirds, a remarkable achievement, from 126 per 1,000 live births in 1990 down to 43 in 2015.
That's a huge drop.
Huge. India actually came incredibly close to achieving the Millennium Development Goal 4, MDG4, which targeted a U5MR of 42 by 2015, missing it by just one single number.
So close. Must have been frustrating, but also motivating.
I imagine so. Between 2000 and 2016, the IMR declined by a significant 50%, and the NMR decreased by 45%.
Significant progress there, too.
However, a persistent and particularly difficult hurdle has been the early neonatal mortality, those deaths occurring under 7 days of life, which the source explicitly states has been less amenable to change.
That first week again, the really tough nut to crack.
Exactly. In 2016 alone, there were 9.8 lakh, that's 980,000, under 5 deaths, and 5.7 lakh, or 570,000, neonatal deaths in the country. Still massive numbers.
Absolutely massive.
To aggressively address these remaining challenges, the National Health Policy 2017 set ambitious new targets, reducing U5MR to 23 by 2025, IMR to 28 by 2019, and NMR to 16 by 2025.
Ambitious targets signal continued commitment.
Definitely. If we connect this to the bigger picture, the persistent difficulty in reducing early neonatal mortality suggests deeply rooted issues, perhaps related to intrapartum care during labor and delivery.
Very likely. Or birthing practices, or the quality of immediate and post-birth interventions, like resuscitation or managing complications right at birth.
That period of immense physiological transition.
Exactly. It strongly points to the need for highly focused and sophisticated strategies, specifically during that critical first week of life. The ambitious 2017 targets reflect a profound and tangible commitment, demonstrating the government's recognition of the unfinished agenda and its determination to align with global health goals and best practices.
It shows they're looking closely at the data.
It indicates a continuous data-driven evaluation and recalibration of strategies based on precisely where the most challenging remaining hurdles lie.
So let's look at why children are still dying. This isn't just a list of diseases. It's truly a blueprint for targeted intervention, showing precisely where medical and public health efforts need to be focused.
The proximate causes.
Right. Our source meticulously details the 8 most important proximate causes of under 5 mortality in India, along with their percentage contributions. Leading this heartbreaking list are complications of prematurity.
Prematurity, 24%.
Accounting for a significant 24% of deaths, making it the single leading cause. This is followed by pneumonia at 13%, neonatal infections at 12%.
Infections are high up there.
And then diarrheal diseases and birth asphyxia, both contributing 11% each.
Diarrhea and lack of oxygen at birth, still major killers.
Yes. Lesser but still significant causes include congenital malformations at 4% and measles and injuries, each at 3%.
Measles still causing 3% highlights the importance of vaccination.
Absolutely. Other disorders, meningitis, malaria, and other neonatal conditions make up the remaining percentages. It's crucial to note, and the source's figure makes this clear, that a significant portion of these causes are concentrated in the neonatal period.
Right, the first 28 days.
But beyond these immediate medical causes, our source points to critical underlying determinants. These are broader societal and environmental factors.
Root causes, in a way.
Like poverty, illiteracy, low caste status, rural habitat, harmful cultural practices, and alarmingly poor access to safe water and sanitation.
The social determinants of health, writ large.
And a particularly critical underlying intermediate risk factor that amplifies everything else is undernutrition.
Undernutrition. We touched on this.
It's shockingly associated with about 45% of all under 5 child deaths.
Almost half. That's incredible.
Undernutrition doesn't just impact immediate health, it directly causes stunting and wasting, profoundly predisposes children to severe infections, and is even associated with adult disorders and a reduced lifetime economic productivity.
This section powerfully raises an important question. How do we effectively and comprehensively address both the immediate medical causes of mortality and the deep-seated socioeconomic and environmental determinants that so profoundly amplify them?
It's a complex puzzle.
It is. What's absolutely fascinating and indeed alarming here is the critical and pervasive role of undernutrition, contributing to almost half of all under 5 deaths. It's not just a standalone issue, it's a foundational vulnerability.
It weakens their resilience.
Exactly. It significantly weakens a child's resilience, making them far more susceptible to every other cause of illness and reducing their ability to recover. This highlights that child mortality isn't purely a healthcare problem, it's a profound systemic development problem.
Linked to equity, food security.
Intrinsically linked to issues of equity, food security, and fundamental human rights. Addressing undernutrition is not merely about feeding children, it's about building their intrinsic biological resilience, securing their cognitive development, and laying the groundwork for a healthier, more productive future for them and, by extension, for the nation as a whole.
It's investing in human capital.
At its most fundamental level.
Moving from the complex problems to the ingenious solutions, it becomes clear that child health has been at the absolute core of India's health policy for decades.
A long-term focus.
This isn't just a simple list of isolated programs, it's a dynamic policy evolution, showing how India's strategic approach became progressively more comprehensive, integrated, and far-reaching.
You can see the pieces coming together over time.
Exactly. It started with pioneering initiatives like the Universal Immunization Program, or UIP, launched way back in 1985, initially focusing on immunization against 6 crucial diseases: tuberculosis, polio, diphtheria, pertussis, tetanus, and measles.
The foundational vaccines.
Right. This was complemented by targeted efforts like the Diarrheal Disease Control Program, initiated in 1981, and the Acute Respiratory Infections Control Program in 1990. Then, in 1992, India introduced a truly strategic shift with the Child Survival and Safe Motherhood, or CSSM program.
The SSM, yes. Integrating child and maternal health.
Precisely. This program intelligently combined core child survival interventions, immunization, control of diarrhea and respiratory infections, vitamin A, essential newborn care with crucial maternal health components like antenatal care, promoting institutional deliveries, and ensuring access to emergency obstetric care.
Recognizing that linkage is vital.
Absolutely. In 1997, the Family Planning Program was wisely merged with CSSM to create the Reproductive and Child Health Program, or RCH, creating a more holistic approach. And in Phase 2 of the RCH program in 2005, an adolescent health component was thoughtfully added.
Extending the continuum of care.
Extending care beyond early childhood. That systematic evolution is key.
It is. If we connect this to the bigger picture, the chronological merging of these programs from CSSM into RCH, and then RCH being integrated into the subsequent missions, indicates a very clear and strategic move towards a holistic and integrated approach to public health.
It makes sense. Child health doesn't exist in a vacuum.
Exactly. It explicitly acknowledges that child health cannot be siloed. It thrives and is profoundly dependent upon a robust maternal health framework and a broader public health infrastructure. This systematic evolution demonstrates a growing understanding of the interconnectedness of health issues and the need for a seamless continuum of care.
And the emphasis on demand-side interventions.
That's particularly crucial. It's not just about passively providing services, but actively empowering communities and families to seek and utilize that care.
Like the ASHAs.
Exactly. The deployment of a massive grassroots workforce like the accredited social health activists, or EHAs, and the sustained focus on strengthening primary healthcare infrastructure are absolutely indispensable for reaching vast and diverse populations, especially in the most remote rural areas of India. This is a monumental effort in scale and scope.
Following this evolution, the government then launched the National Rural Health Mission, or NRHM, in 2005. This mission represented a monumental investment in public health.
NRHM was a game changer.
Focusing extensively on health system improvements, deep community engagement, decentralization of services, and strengthening those demand-side interventions we just discussed, all designed to enhance program effectiveness and reach. The RCH program was seamlessly integrated into the NRHM, maintaining its prime focus on child and maternal health within this broader framework.
Keeping that core focus strong.
The strategies employed were truly multifaceted. Deployment of over 900,000 ASJs. That's an incredible grassroots army.
900,000. Just imagine that scale.
An increase in auxiliary nurse midwives, or A&Ms, other nurses and doctors, establishing village health and sanitation committees, strengthening primary healthcare infrastructure, improving program management, establishing patient welfare committees, and creating crucial emergency transport networks.
Addressing multiple system bottlenecks simultaneously.
Right. In 2013, under the 12th Plan, the government critically reviewed the maternal and child health program under NRHM and launched an even more refined strategic approach. RMNCH plus A.
Reproductive, maternal, newborn, child, and adolescent health. RMNCH plus A captures that whole continuum.
Exactly. And finally, with the advent of the National Urban Health Mission, NUHM, the NRHM is now simply called the National Health Mission, or NHM, reflecting an even broader pan-national scope covering both rural and urban health needs.
So NHM is the current umbrella.
Let's now take an even deeper dive into the RMNCH plus A framework, which really outlines the specific actionable services India provides, emphasizing that crucial continuum of care.
Okay, the services under RMNCH plus A.
Starting with pregnancy, childbirth, and immediate newborn care, the interventions are designed for critical impact. Skilled obstetric care, essential newborn care, including resuscitation.
That Navjat Shishu Suraksha Karyakram training.
Yes, ensuring competence at birth. The focus is on dramatically increasing facility deliveries by skilled birth attendants, ensuring emergency obstetric and newborn care, EMONC, is widely available.
Having those emergency services ready.
And providing essential basics like warmth, strict hygienic practices, early breastfeeding initiation, extra care for small babies, and rapid sickness detection for newborns. This also includes establishing vital linkages to higher-level facility-based newborn care for sick neonates.
Connecting the levels of care.
The program drivers here are incredibly vital and innovative. Postpartum care for both mother and baby, and perhaps most impactful, the Janani Suraksha Yojana, or JSY.
JSY, the cash incentive scheme.
Right, a direct cash incentive to the mother and to the ASA for ensuring delivery occurs in a health facility. Additionally, the Janani Shishu Suraksha Karyakram, or JSSK.
JSSK, the Free Services Entitlement.
Yes, addresses other critical access barriers, uniquely entitling both the mother and the infant to completely free delivery, essential medicines, blood transfusions if needed, dietary support, and even free pickup and drop services for government facilities.
Removing cost and transport barriers. That's huge.
This section truly highlights the uninterrupted continuum of care, from before birth to the immediate precious moments after, emphasizing skilled assistance and addressing fundamental socioeconomic barriers.
What's particularly powerful here are those strategic cash incentives under JSY and the comprehensive free services under JSSK. This raises an important question. How do these demand-side interventions directly and dramatically impact institutional delivery rates and, consequently, child survival?
You can see the logic. Make it free and easy.
By directly removing significant financial and logistical barriers, these programs actively encourage families to opt for safer facility deliveries. That's crucial for reducing birth-related complications and ensuring immediate access to trained personnel and essential newborn care.
It makes the choice much simpler for families.
Exactly. For instance, imagine a family in a remote village, previously unable to afford hospital delivery. JSY and JSSK make that vital journey possible, instantly improving the chances of survival and health for both mother and child. These are not just policies, these are practical, tangible mechanisms that translate policy into direct, life-saving public health impact at scale.
Moving on to newborn and child care, this is where we see India's truly impressive tiered system in action, extending from simple home visits all the way to sophisticated high-tech units.
The different levels of care delivery.
First, there's home-based newborn care, primarily delivered at the community level by those indispensable ASHAs. They conduct 6 crucial home visits for facility-born babies on days 3, 7, 14, 21, 28, and 42 after birth.
A structured schedule of visits.
With an additional extra visit on day 1 for babies born at home, addressing that critical early neonatal vulnerability.
Covering home births, too. Important.
During these visits, they provide vital interventions for infants. Basic examinations, counseling for warmth, essential breastfeeding practices, hygiene, extra care for low birth weight babies, early detection of sickness, and prompt referral when needed.
Basic but life-saving checks and advice.
For mothers, they provide essential postpartum care and crucial counseling for family planning. The program driver here is a vital incentive paid to the ASA for providing this home care, meticulously recording birth weight, ensuring birth registration, and facilitating immunization.
Incentivizing the ASJ's critical role.
Then, for more complex needs, we have facility-based newborn care, which includes 3 escalating levels of care. At the top are special newborn care units, or SNCUs.
SNCUs, the highest level for newborns.
Sophisticated, specialized units, typically at district hospitals, equipped with advanced medical tools like radiant warmers, 16 beds, meticulously staffed by physicians, nurses, and support staff for around-the-clock, highly specialized services for newborns requiring intensive care, VLBW, sepsis, pneumonia, common complications.
Intensive care capacity at the district level.
A crucial step down from SNCUs are newborn stabilization units, or NBSUs.
NBSUs, located in CHCs.
Yes, strategically located in community health centers. These units stabilize babies referred from peripheral areas, offering immediate life-saving services like resuscitation, warmth, breastfeeding initiation, infection prevention, cord care, supportive care, oxygen, IV fluids, monitoring vital signs, and efficient referral to higher centers when needed.
A vital stabilization point before potential transfer.
And at the most primary level, ensuring immediate care at birth, newborn care corners, or NBCCs.
NBCCs, right in the delivery room.
Special designated areas within labor rooms at all facilities, PHCs, CHCs, district hospitals where deliveries occur, they're essential services. Immediate resuscitation, warmth, infection prevention, early initiation of breastfeeding. Again, JSSK is a key program driver across these facility levels, entitling infants to free services.
Making sure basic resuscitation is available everywhere.
Lastly, under this comprehensive umbrella, is the Integrated Management of Common Childhood Illnesses, or IMNCI.
IMNCI, a standardized approach.
This crucial service is provided by those frontline ANMs and at the first-level health facilities, like a PHC. There's also facility IMNCI delivered at the first referral level, such as CHCs, which focuses specifically on inpatient management of the major causes of childhood mortality we discussed earlier.
Asphyxia, sepsis, LBW, pneumonia, diarrhea.
Exactly. Asphyxia, sepsis, low birth weight, pneumonia, diarrhea, malaria, meningitis, and severe malnutrition. JSSK also plays a vital role here, entitling infants to free services for these conditions.
So IMNCI covers both outpatient and inpatient management.
This is truly an impressive and intelligently tiered system, ensuring that no child falls through the cracks and can access appropriate escalating care based on their needs wherever they are born in India.
If we connect this to the bigger picture, this comprehensive layered approach from home-based primary care to highly specialized tertiary care is absolutely vital and strategically brilliant for a country with such diverse geographical and socioeconomic landscapes.
A one-size-fits-all wouldn't work.
It simply wouldn't work in India. It demonstrates a profound understanding of that. It also powerfully highlights the strategic shift towards managing childhood illnesses integratively, rather than as isolated conditions, which is crucial for complex pediatric cases where multiple factors may be at play.
Right, kids often have multiple issues.
The meticulous detail in defining the roles and services at each level, from the ASJ's foundational home visit to the highly specialized equipment and staffing in an SNCU, is a testament to a well-thought-out, scalable public health intervention designed to address the specific vulnerabilities of newborns and children at every stage of their early lives. It's truly a masterclass in large-scale public health implementation.
Next, let's talk about immunization, which is truly the shield against disease, a foundational pillar of public health. The Universal Immunization Program, or UIP, has been a cornerstone.
UIP, absolutely fundamental.
It now robustly includes 7 essential vaccine-preventable diseases: BCG, polio, diphtheria, pertussis, tetanus, measles, and hepatitis B. Our source notes that this program has received a significant and intensified push through Mission Indradhanush.
Mission Indradhanush to boost coverage.
To ensure absolutely no child is left behind, aiming for 90% coverage. Beyond these core vaccines, India has continuously demonstrated a dynamic and responsive approach by introducing additional newer vaccines.
Keeping the schedule updated.
These include the pentavalent vaccine, DPT, Hep B, HIB, OPV supplementary doses on national immunization days, injectable polio vaccine, IPV, and the MR, measles and rubella vaccine.
Expanding protection.
Critically, Newer impactful vaccines like the rotavirus vaccine have been strategically introduced in selected states to combat diarrheal diseases.
The huge burden, rotavirus.
And the pneumococcal vaccine has been initiated in selected states as well to fight severe pneumonia. For endemic districts, the Japanese encephalitis B vaccine is intelligently combined with routine immunization.
Tailoring vaccines to local disease patterns.
The expansion of the UIP and the focused, mission-driven effort of Mission Indradhanush are absolutely critical, acting as the very front lines of prevention, stopping diseases before they even have a chance to start.
What's fascinating here is the continuous evolution and expansion of the immunization schedule, systematically integrating newer, critical vaccines like rotavirus and pneumococcal vaccines. This clearly reflects an adaptable, evidence-based, and forward-looking public health strategy,
Responding to the burden of disease.
consistently aiming to tackle the most prevalent and impactful causes of morbidity and mortality among children. Mission Indradhanush, with its dedicated focus on reaching every single child, powerfully underscores the commitment to equity and universal access,
Leaving no one behind.
recognizing that even a single unvaccinated child can pose a risk to the entire community. This dynamic and responsive approach to immunization is a powerful example of how public health programs must constantly adapt to new scientific knowledge, evolving disease burdens, and global best practices to protect the most vulnerable.
Then we have child health screening and early intervention services, delivered under the incredibly comprehensive Rashtriya Bal Swasthya Karyakram, or RBSK.
RBSK screening and early intervention.
This program was launched in January 2013 with the ambitious goal of providing child health screening and early intervention services through dedicated mobile health teams operating at the block level, bringing care closer to communities.
Mobile teams reaching out.
It mandates the systematic screening of all children from birth up to 6 years old, at least twice a year, for an extensive list of 30 specific disorders.
30 disorders twice a year. That's comprehensive.
These disorders are intelligently categorized as the 4Ds, a useful framework. The 4Ds are defects, like neural tube defects, Down syndrome, cleft lip palate, clubfoot, congenital heart diseases,
Major structural issues.
deficiencies covering crucial nutritional issues like anemia, vitamin A, vitamin D deficiency, severe acute malnutrition, goiter,
Linking back to nutrition again.
diseases like skin conditions, ear infections, rheumatic heart disease, dental caries, convulsions, and finally, developmental delays and disabilities.
The fourth D. Critically important.
Covering vision or hearing impairment, neuromotor impairment, motor delay, cognitive delay, language delay, behavior disorders, learning disorders, ADHD.
A very broad developmental screen.
The program also includes optional screening for congenital hypothyroidism, sickle cell anemia, beta thalassemia. But what's truly monumental and transformative is that children identified with any of these conditions receive free management
Free management, that's the crucial intervention piece.
at designated district early intervention centers or identified tertiary level institutions, screening for 30 disorders twice a year for all children up to age 6, and then providing comprehensive free management that's an absolutely monumental undertaking.
It really is. Focusing on early detection and preventing lifelong disabilities.
Fundamentally altering a child's life trajectory.
This program's depth immediately raises an important question. How does early detection of conditions like congenital heart diseases or developmental delays fundamentally alter a child's life trajectory?
It must make a huge difference.
It's not just about survival. It's about preventing long-term disability, minimizing the impact of these conditions, and dramatically improving the overall quality of life. Early intervention for hearing or vision impairment, for instance, can be truly transformative.
Allowing them to learn, integrate.
Exactly. Access education, achieve their full potential. The significant focus on deficiencies also directly links back to the crucial and pervasive role of undernutrition we discussed earlier, reinforcing the interconnectedness of health determinants.
It's all linked.
This comprehensive screening and intervention program is a proactive and strategic investment in human capital, ensuring that preventable conditions don't become lifelong burdens, thus strengthening the future workforce and societal well-being.
At the crucial grassroots level, 3 roles form the absolute backbone of India's child health programs, especially in its vast rural areas: the GHAI, the AWW, and the ANM.
The frontline workforce.
They are the eyes, ears, and hands on the ground, making direct contact with families. The GHAI is absolutely crucial for mobilizing pregnant mothers for antenatal checkups, accompanying them for delivery, providing home care for newborns and postpartum mothers.
The community mobilizer and first contact.
They also facilitate immunization, promote complementary feeding, provide primary care for diarrhea and pneumonia, and offer vital health education. The AEWW, the Anganwari worker, is primarily responsible for nutrition supplements,
Nutrition focus for AEWWs.
providing nutrition supplement to pregnant mothers and children, facilitating antenatal checks and immunization, promoting infant and young child feeding, growth monitoring, managing malnourished children, and even non-formal preschool education.
Health and early development combined.
Lastly, the ANM, the auxiliary nurse midwife, serves as a critical link, facilitating antenatal checks, carrying out immunization, supervising AHAs and AWWs,
The supervisor and skilled provider link.
providing essential IMNCI services for neonates and children, and delivering broader health education. These three roles, working in concert, are the vital human bridge connecting vast communities to healthcare.
What's truly fascinating here is how these three distinct but interconnected roles powerfully demonstrate the decentralized, community-focused approach that is central to India's health strategy.
Taking healthcare to the doorstep.
They effectively bridge the often vast gap between centralized clinical services and the household, directly implementing vital interventions like home visits, nutrition support, and early detection at the most local and accessible level. This grassroots team is absolutely crucial for reaching the last mile,
Ensuring services reach everyone.
ensuring that even in the most remote or underserved areas, families have access to essential care and information. Their integrated efforts are fundamental to the success and scalability of the broader national health programs we've discussed, turning policy into tangible health outcomes for millions.
Beyond the expansive RMNCH+A framework, India has also launched several highly targeted strategic initiatives, focusing on specific high-impact areas where further concentrated effort is needed.
Fine-tuning the approach.
For adolescents, there's the revamped Rashtriya Kishore Swasthya Karyakram, focusing on nutrition, sexual and reproductive health, mental health, injury prevention, substance misuse, and NCD prevention.
Addressing that crucial adolescent transition.
For newborn survival, the Indian Newborn Action Plan, INP, launched in 2014, commits the country to a single-digit NMR and stillbirth rate by 2030.
INAP. Very ambitious targets for newborns.
We mentioned Mission Indradhanush earlier, launched 2014, the National Immunization Drive aiming for 90% coverage by 2020.
Intensifying immunization efforts.
And to combat a persistent threat, the Intensified Diarrhea Control Fortnight, IDCF, observed annually since 2014.
IDCF. Focusing on a major killer.
Intensifies efforts to reduce child deaths from diarrhea through mass awareness about prevention and immediate treatment with ORS and zinc tablets.
ORS and zinc. Simple, effective interventions.
Finally, a significant new program, Home-Based Care of Young Child, or HBYC, introduced in 2018, 3 crucial monthly home visits by ASAs from 3 to 15 months.
HBYC. Extending home visits beyond the newborn period.
Aims for correct complementary feeding introduction at 6 months. Adequate nutrition, continued breastfeeding, immunization counseling, early care seeking for diarrhea and pneumonia, growth monitoring, care of undernourished early childhood development, hygiene sanitation.
A comprehensive package for that critical post-6-month period.
These are not just add-ons. They are highly targeted strategic initiatives focusing on specific high-impact areas, demonstrating a dynamic and responsive health system.
This collection of specific initiatives raises an important question. How do these highly focused programs complement and strengthen the broader national health mission framework?
They seem to fill specific gaps.
They clearly demonstrate a continuous refinement of strategy, adapting to real-world data and aiming for even more granular and impactful interventions in critical areas. The INP's 2030 target for single-digit NMR is a bold, globally aligned commitment.
Setting a high bar.
Similarly, the IDCF and HBYC programs are direct, evidence-based responses to leading causes of child mortality and malnutrition, showcasing a proactive and data-driven approach to public health. These initiatives powerfully illustrate that effectively addressing child health is a dynamic, evolving process requiring constant innovation and targeted interventions alongside broader systemic reform,
All working together.
all working synergistically towards a healthier future.
All these concerted efforts, coupled with India's impressive overall socio-economic development, are clearly paying remarkable dividends.
Seeing the results.
These figures are concrete, undeniable proof that the strategies are working and creating tangible change. Our source points to a truly remarkable jump in the institutional delivery rate,
We mentioned JSY and JSSK helping there.
which now stands at over 80%. This is a massive achievement, especially considering it was just 39% a mere decade ago.
Over double in a decade. Incredible.
This dramatic increase signals significantly safer births and immediate access to trained medical care for both mother and child, right when it's most critical. In terms of specific program outcomes, the 2015-16 data shows significant progress. Full immunization coverage reached 62%.
Up from 44% in 2005-06. Good progress.
And the use of oral rehydration salt, ORS, for diarrhea treatment, that simple lifesaver, increased to 51% from just 26% in 2005-06.
Doubled ORS use. That saves lives directly.
These improvements are tangible signs of a profound and positive shift in child health outcomes across the country.
What's particularly fascinating here is how the progress in institutional delivery, immunization coverage, and ORS used directly and unequivocally correlates with reductions in vaccine-preventable diseases and diarrheal deaths, two of the major causes of child mortality we discussed earlier.
The interventions are hitting the targets.
It provides compelling evidence of the real-world impact of focused public health campaigns, strategic infrastructure development, and community-level engagement. If we connect this to the bigger picture, these indicators are absolutely crucial for meeting broader national health and development goals and demonstrate a very strong return on investment in public health.
The scale of it is just impressive.
The sheer scale of this progress, particularly the dramatic jump in institutional deliveries, is a testament to the effectiveness of those demand-side interventions and the robust community-level engagement we explored earlier. It shows what's possible with sustained commitment and targeted strategy.
This isn't just about treating illness anymore. It's about building a robust, universally accessible health infrastructure and proactively addressing the fundamental financial barriers to care.
Systemic change.
Our source emphasizes that the nation is addressing child health challenges with greater dynamism than ever before, a clear acceleration of effort. There's significant and sustained investment in health programs and continuous health system strengthening.
Maintaining momentum.
Crucially, complete conditional cash transfers and entitlements are now legally enshrined to stimulate demand for maternal, newborn, and child health care, ensuring families can access these vital services without undue financial burden.
Making those entitlements robust.
Child health and survival are explicitly positioned at the core of the National Health Policy 2017, as well as being central to India's commitments for the Global Sustainable Development Goals, or SDGs.
Aligning national and global goals.
A major, potentially game-changing initiative announced in 2018 is the Ayushman Bharat initiative. This encompasses two key pillars.
Ayushman Bharat, big news.
First, strengthening primary health care by developing 150,000 health and wellness centers across the country, fundamentally decentralizing access.
Strengthening the foundation.
And second, providing unprecedented financial protection for hospitalizations for 100 million families. That translates to an astounding 500 million persons.
500 million people covered for hospital care.
The latter is particularly impactful for pediatric care, enabling cashless access to inpatient treatment for often incredibly costly pediatric and neonatal illnesses, removing a monumental barrier for vulnerable families.
Removing that catastrophic cost barrier for hospitalization.
Additionally, broader national initiatives like the Swachh Bharat mission focusing on sanitation are also expected to significantly help reduce ill health by improving environmental determinants.
The link between sanitation and health.
All these factors combined position India to attain low child mortality rate and improve remarkably the health and nutrition status of her children in near future, truly pointing towards a brighter tomorrow.
This comprehensive approach raises an important question. How does universal financial protection, like that offered by Ayushman Bharat, fundamentally remove a key barrier for millions of families seeking specialized pediatric care?
Cost is often the biggest barrier.
It ensures that economic status no longer determines a child's access to life-saving and often very expensive medical interventions. That's absolutely critical for achieving equitable health outcomes across such a diverse population. The seamless integration of child health goals with overarching national policies like the National Health Policy 2017 and broader intersectoral initiatives like Swachh Bharat.
It's a whole-of-government approach.
It truly makes child health a holistic, whole-of-government endeavor. It shows a sophisticated understanding that health is not just about medical treatment, but about a supportive, enabling ecosystem that includes financial accessibility, robust sanitation, and comprehensive community well-being.
The trajectory looks promising.
This level of sustained commitment, strategic investment, and integrated infrastructure development suggests a very strong and promising trajectory toward significant and lasting improvements in child health across India, setting a powerful example globally.
So what does this all mean for you, our listener? We've embarked on an incredible deep dive, exploring the intricate journey of pediatrics in India.
From principles to practice.
From understanding the foundational principles and the unique biology of children, to grappling with immense, large-scale challenges like high child mortality, and then meticulously detailing the development and implementation of innovative, multi-layered solutions.
It's been quite a journey.
It's a profound testament to sustained national effort, a clear strategic vision, and an ever-evolving understanding of public health executed on a truly massive, unprecedented scale.
Indeed. If we connect this to the bigger picture, this entire narrative powerfully demonstrates that public health is an ongoing, dynamic process of adaptation, continuous innovation, and unwavering commitment.
It never really stops.
Despite the impressive progress achieved and the ambitious targets that have been met or are now firmly within reach, the unfinished agenda means constant vigilance, continuous refinement, and relentless effort are still required. What's truly fascinating here, and a model for the world, is the sheer scale of India's achievement given its vast population and its diverse challenges.
And the framework it provides.
And the comprehensive framework it offers for other developing nations striving to profoundly improve child health outcomes.
What an illuminating deep dive. You now have a truly comprehensive and professional level understanding of pediatrics in India, its unique challenges, its rich historical evolution, and the groundbreaking programs shaping its future.
Hopefully a much deeper appreciation.
This isn't just about healthcare, it's about the very foundation of a nation's strength, its economic prosperity, and the boundless potential of its coming generations.
This experience raises an important question for you to ponder, one that resonates far beyond India's borders. As countries globally continue to advance scientifically and economically, what collective responsibilities do we as a global community bear to ensure that the most vulnerable among us, our children, wherever they are born, truly attain their highest possible potential?
Not just surviving, but thriving.
Exactly. Not just surviving, but thriving.
A powerful thought to leave you with indeed. Thank you for joining us on this deep dive into the heart of child health.